I wanted to talk briefly about a couple of other tools out there that are gaining traction. I think these are very innovative techniques and tools at our disposal. The question is, how, now that we have all this new technology, how are we using all of this information, the data, the materials, to sort of build a tailored solution for each individual patient? I include this picture up here. It's one of my best friends here in Cincinnati. He owns a tailor shop, and a lot of people in here probably know him. Certainly Tobes knows him well. His name's Trevor Furby, and he has an extremely successful business over in Marymount that's expanded up to Columbus. It's expanding in Indiana to Michigan. And, this guy has built his entire career and success off of finely tailored clothing. So in my mind, the question is, if we are committing that kind of effort and expense to our clothing and the things that we wear every day, why aren't we looking at spine surgery the same way? So how do we tailor individual plans to each individual patient, their pathology, their objective and subjective factors to improve efficiency and enhance outcomes? So the history of spine surgery and spine fusion is a long one, extending from the times when we used to take iliac crest bone graft for every ACDF and leaving patients with a pain that forced them to focus on their hip and not their neck. Harrington rods and hooks, and then finally with the evolution of pedicle screws in the 90s, as we've already briefly discussed, we finally had a great tool and powerful tool to instrument the spine with an internal brace to allow for fusion to occur. But it's more than just instrumentation, right? So we have to pair the instrumentation, we have to pair our material or our instruments with other materials to exact a correction or a result. And so we have these, various rods of various stiffness. Peak rods are an option as well. I didn't include those on there. We have connectors. We have different kinds of pedicle screw heads, screws that can accept multiple rods, et cetera. So the way that I kind of started thinking about this is, we're not at the point where we can just make something specific and unique to every patient. So how do we use a combination of these materials to achieve a result for specific patients? So a few years ago, taking this concept, we developed a technique with dual-headed pedicle screws, at this time the DRMAS screws from Medtronic, and in conjunction with our multiple materials from NuVasive, to use combinations of different rod stiffness to soften the landing above, which has proven to be a pretty effective means of avoiding PJK. It's obviously technically a little more demanding. There's more fiddle factor, maybe increases operative time, those kinds of things. But to this date, of the 70 or so patients we have, I've had 2 revisions and extensions, both in patients who had a traumatic event about a year or so after surgery. So this is, again, I include this and talk about it because this was sort of my foray into this concept that we shouldn't be using the same thing for every patient, because up until this point, it was kind of like, we've got to make the best of what we got. So you just choose the pedicle screw that you use at S1 or into the pelvis is the same screw with the same cap and the same tulip as a screw you use in T9, which is the same that you use in a woman with a DEXA score of -1.5 at the hip, and it's the same as the 300-pound guy who's got bone like granite, right? So we're using those same instruments in 2 totally separate patient populations. So the question is, can we start to now take these materials and alter them to match the biomechanical demands of different regions of the spine? And I think SI Bone's done a good job of introducing this concept with their torque and granite screws. I think there's some pluses and minuses to the way that we think about this, but we've talked about XLIF as one of the most transformative approaches or techniques in spine surgery over the last 15 to 20 years. And I'd echo that, and there are 2 more. This is one of them. I think by incorporating SI fusion with my long segment constructs, which we've done maybe 300 cases myself since its inception, we've basically obliterated the, and I never say 100%, because nothing's ever 100% in medicine, nothing's 0%, as David once taught me. that we've basically eliminated SI joint pain from our deformity practice, which when you get out there and start practicing and you start doing these cases, patients are doing great, and 25 to 30% of them are going to come back with this nagging SI joint pain that you got to deal with. That problem is almost gone. Distal junctional failure has all but decreased in our practice, or is all but gone in our practice as well as a result of this. You still have them in unique situations, but it's far less than it was before. So we got to start thinking that way. So why is it? If you guys know, it doesn't matter if you put in a 9.5 millimeter pelvic screw or a 10.5 millimeter pelvic screw. You know where the weak point of that screw is currently, when just about every other iteration is at the interface with the tulip. It's a 5.5 or 6.0 shank at the interface with the tulip. So it doesn't matter how strong it is, it's still going to break at the same spot, right? So that's where I think that's where we need to go with our materials. So aside from materials, we started looking into outcomes in deformity surgery and what mattered when it came to providing good outcomes for patients. In other words, is there an objective finding that we can go after to shoot for that's going to create happier patients? And I was fortunate enough to be sort of around when this buzz was occurring, and I'll never forget. I think the first time David and I and Adam wrote a paper together with me, we were evaluating the Pittsburgh 360 or 540, yeah, Pittsburgh 540, the spit roast.
That's cool.
Yeah, but we were evaluating the efficacy of utilizing a combination of open and MIS procedures to treat deformities. And the criticism of that paper, the initial criticism when we submitted it for publication, was you guys need to include sagittal parameters. Remember that? So it was all about the coronal curve. And so I didn't know what the hell they were talking about, right? Because that wasn't a thing that was widely known or accepted. So I started doing a deep dive into this, which led to a whole, motivation for me to learn more objectively about spine. So that's sort of the moment when I fell in love with this particular specialty, was that I'm like Alex Thomas. I have a very simple mind, and if you can give me some math and numbers and geometry, the world makes a lot more sense. And it was incredible how much the world of spine surgery opened up to me when we started looking into this. Okay. And then, of course, if we're talking about this in deformity patients, why aren't we talking about it in degenerative cases or any patient who receives instrumentation? And of course, like Alex said, anytime you all have a great idea, someone out there is not going to like that idea. So we wrote a paper on this. And when we submitted it to the Journal of Neurosurgery Spine 3 times, they kept coming back with the same response. So you guys are saying that every patient should have a deformity operation, to the point that in the 3rd iteration of this paper, we actually put a statement in there that says, we are not saying that every patient needs a deformity operation. The point is that it helps you prognosticate, it helps you counsel patients, it gives you information that is very valuable in terms of your decision making. So if you're between doing a lateral or a T-lift, does it push you more toward the lateral because you can maybe be able to get better lordosis unless you're Bill Tobler and your T-lift is equal to a lateral, right? But but the point being is, now all of a sudden we're taking information, objective information, with the materials that we have to develop a solution for a patient that's not a one-size-fits-all solution. And David already talked a little bit about this, so I'm not going to belabor the point, but then you take the data and the information, how do you analyze that, right? So you need to put something in a surgeon's hands that's not cumbersome, that gives them the ability to develop a more accurate plan to guide their decision making. And these are 2 of those early tools in NuvaLine and SurgiMap. And then pair that with intraoperative execution and reconciliation. So tools like Bendini or which can help you stereotactically bend a rod as a guide for your rod placement. In fact, still use Bendini to this day. I basically use Bendini as a template. So that way, when I'm doing my osteotomies, especially in a coronal patient who doesn't need a ton of sagittal correction or where the cages have already done the work, my scrub tech is bending the rod with Bendini while I'm doing osteotomies. So that way, by the time we're ready for rod insertion. All I got to do is fine tune it with my bender. So, these are all kinds of things where you can manipulate your points. You can fashion your rod how you want, again, to taper it to whatever the intraoperative pathology is. So then we had at Metacrea, again, which David talked about and Brian's going to talk about more. So just a word on this, that this is the first platform that took the data, the information, put it into a planning system, and then chew that all up to give you an implant that's specifically made for a patient. So this is sort of that first time that we're seeing all of that come together toward a tailored plan for patient-specific surgery. Got it. Again, we talked a little bit about this. I don't want to go too far into this with Brian's talk coming up. So is there a better vehicle for delivering and analyzing this information? So where are we getting our correction from? And it's no secret that anterior column reconstruction and lateral and anterior approaches have become a powerful alternative to big open osteotomies or third column osteotomies. And in that scenario, can we utilize interbodies as a vehicle for delivering the information that we're looking for in the data? So a few years ago, a company called Carlsmed came out with their Aprevo interbody, which, correct me if I'm wrong, but I think that was a dentist, right, who developed this idea, because in dentistry, I guess it's very common to make dental implants that are specifically designed and 3D printed. So took that same information to develop patient-specific interbodies, and same concept as the unit platform in the preoperative planning. You can develop a plan based on corrective goals. We'll analyze your preoperative data to come up with a series of interbodies and shapes, geometries, et cetera, that are contoured to specifically maximize end plate contact and enhance corrective abilities. And in the scenario, not only do you have, again, a plan, but you've been delivered the vehicle through which you can achieve that plan more easily and seamlessly. And if you want, you can go about as deep as you want into this. You can change just about every measurement on these cages if you're that into numbers. And you can talk to an engineer and they'll change it up and give you a new plan. And you have an app on your phone that you can even show your patient and say, you've got, this is what we're doing specifically for your condition. And in this day and age, like I said, I think those things become increasingly important because patients are smarter now than they've ever been, even if it's with this information. And they want their care to be delivered to them in a specific way these days. So very powerful technology here to digest. So you've taken all this, you got all this new technology, all this data, all this information. How do we wrap it all together? So not to belabor this point too much, but we have technology in the OR, we have implants. All these things cost money, they take time, they take manpower. So where we're going next is to start integrating all this technology into seamless platforms. And I think what we're going to see with robotics and AI and all these new developments moving forward is that you're going to have a one-stop shop to develop a tailored surgical plan for each individual patient. Starts with preoperative planning, intraoperative execution, reconciliation, and postoperative follow-up. So I'm going to stop there with this so we can kind of get a little bit back on track, give Brian his talk, and we'll take any questions.
Just maybe not too much to talk about, but wasn't mentioned, but Metacrea is, I know it's about the technology and software, but really for the surgeon, what attracted me is that I'm not a metallurgist. I don't understand metallurgy very well, but the point of Metacrea was that rod was poured in the shape so that
and not bent, right? So
that you're not, and I'm not trying to really slam Bandini, but Bandini's a wonderful tool, but you are manipulating that rod over multiple segments.
Mhm.
I think from a metallurgical point of
Not
view.
notch sensitivity is the term.
Yeah, notch
Notch
sensitivity.
Yeah.
Right.
Is the term.
Yeah.
That every time
Right.
you
Right.
bend it, you
But,
introduce.
but that is really an unspoken benefit of the Metacrea system,
Mhm.
is that you have a purely poured rod
Mhm.
and it's not been manipulated. And when it's manipulated, it creates stress risers.
Right.
and points of potential failure. And I'm not sure, there've been some studies that have been published. I don't know what current studies are out there, whether that's been further proved or disproved, or there's any data
Well, I think
about that.
the important point here is something David brought up earlier, right? Which is with advanced material science and with our new biologics, it's rapid early osseous integration, right? Because if you don't fuse, right, all rods are going to succumb to stress, right? And they'll break regardless, no matter how well the rod is bent or contoured or what material it is. And personally, I think with biologics and with lateral cages, anterior cages, you don't see as many broken rods now as you used to, because patients are fusing so much more robustly. Now, I still see it to this day. I it's probably now like once a month where I just curse for 20 minutes straight about the evasive base gauge. which was a hollow chunk of titanium with a humongous aperture in the middle of it for fusion. And I still see patients come back 5 years later who finally break a rod after a smoldering pseudoarthrosis. And they may even be fused now, but not until that rod succumbed to some amount of stress and broke, right? And so I think by enhancing, getting, developing more accurate corrective goals, and utilizing implants that have more implant contact, diffuse the stress better across the space, and have better osseous integration, you mitigate a lot of that risk.
Well, once the fusion occurs, once the interbody fusion occurs, there's no more stress on the rod.
Right. Well, minimal, much less. Yeah.
Zach, the question is purely from ignorance, because I don't use Metacrea rod, and I certainly don't use the custom interbody spacers. What percentage of time would you say your preoperative planning that is used to determine the contour of this rod that you order from Metacrea, or the spacer that you order from Carlsbad?
Yeah.
What percentage of time does it happen where postoperatively didn't quite line up with what you thought you were going to get, and now the rod doesn't quite line up?
Yeah.
Does that make sense?
Yeah, absolutely. So that was my big concern, and I don't use Metacrea much anymore. If Brian's going to talk about that, I'll defer to him to that during his talk or after his talk. But when it comes to the interbodies, the Carlsbad interbodies, I've probably done 20 something cases. That was my big concern as well. And the way that I started using it was, I had a couple patients with weird hemivertebra, and I started thinking to myself, if I can make up 50% of the coronal correction for that through an anterior approach, and I don't feel safe because I don't want to just put a standard stock cage in next to a hemivertebra, then I'm going to make my posterior work a lot easier. And I will say, and this is going to sound strange to say, but in many ways it's easier to achieve those goals with that cage, because it's contoured to the end plate. You don't have to be perfect in how you insert it, almost, because it's going to go where it's supposed to, because it's going to settle in that spot because it's built for that end plate, as long as you have good technique and don't screw up the end plates. And I will say that it's like anything else. You got to achieve that posterior release. I think of all the cases, there's one where I thought maybe we could have had more lordosis out of the cage, and some of that's just preoperative planning. And I think if I would have had them dial in more lordosis with the cages, that we would have been in good shape. But I think I might have a case in here, but I can tell you, yeah. So here's a case example actually that I can show you, where again, have a woman who, the classic patient that David was talking about earlier, who I spent 9 months preparing for surgery, not a BMI of 32 like David, but certainly got her from 46 to 37 and a half. That's like a chip shot Cincinnati case. My PA back there is like, yep. So, this woman, obviously bad, three-dimensional deformity, multi-level stenosis, had an autofusion at 5'1". Planned a stage reconstruction, developed this plan, and I'll tell you, it's pretty remarkable. And if you look at, and the best thing is there's no lying in the numbers, right? So Carlsmed, for example, just like Medicrea will, or Unit with Medtronic, will track your post-operative cases. So in fact, you can pull up all of the post-operative data, and it will show you your accuracy compared the plan compared to the execution of the plan. And I don't know, Josh, you'd say pretty accurate, right? Yeah. And this is our achieving our goals of surgery here. So I will say, you always expect something when you adopt new technology, you expect to have a learning curve. You expect to not like something. You expect to have complaints about it or curse its name sometimes. But that's part of being an innovator, right? That's part of innovation, is accepting the challenges and developing solutions to those challenges, and then figuring it out. It's oftentimes not the technology's fault, it's the surgeon's fault, as we discussed. And I'll tell you, so I had an appropriate amount of skepticism when I started using these interbodies, and I was surprised about how accurate and easy it was to do that. But to my next point there on that note is that, three things in my career since when I was a resident that I've seen that are transformative. XLIF is one, open SI fusion deformity cases, and patient-specific interbodies and implants, that third piece of the puzzle. So I think there's a big role for this kind of thing moving forward, once we figure out the efficiency and cost effectiveness of making it.
Along that vein, like the cost efficiency and of actually printing that out for a patient, where do you think the percentage of people that it actually meaningfully helps you would lie in like a patient population?
Yeah, so I think, again, I probably do between 5 and 7 deformities a week. So, and I probably do 1 or 2 cases a month with patient-specific interbodies, which is actually a lot. And because it has a breakthrough design designation, the hospitals actually make money off the implant because of reimbursement from Medicare. So I'm a little more liberal than I otherwise would be, because I'm also trying to push the limits of the technology and use it for interesting things to figure out where it fits best in my practice. But if for someone interested in that technology, what I would say the single best case for a patient-specific implant is someone with an unusual or challenging coronal deformity. Someone with a trunk shift, hemivertebra, where you need a really nasty scalloping of the or degenerative changes in the end plates and the vertebral bodies, where you got wedge shaped stuff everywhere, that kind of thing, because it will give you an idea of how your correction is going to look, as long as you do your job.